Hello, everybody. This is Alex Howard. We're back here for another session here at Forward 50. We're all making it work here, an entirely virtual event, and we're making our brains process quite a bit hanging out in these screens. And all that, of course, generates some data. And that is the subject of today's discussion. Dr. Sean Hill is the director of the Krembil Center for Neuroinformatics at the Center for Addiction and Mental Health Foundation. And he's going to talk about how to transform mental health care through new approaches. Um, and I'm fascinated to hear about this. I'm not going to get in the way of his talk because I want to hear more about how machine learning and computing can give us different ways of understanding how the brain is working or is not working abnormally or normally. But I will, I think, defer to the good doctor on that and give him the floor. I'm looking forward to hearing what you have to say, Dr. Hill.
It's fine. Thank you. It's great to be here. Thanks a lot.
You bet.
So first, it's a pleasure to be here in Forward 50 and talking about some of the work of the Krembil Center for Neuroinformatics. We've got a really significant challenge to tackle, which is that every year there are 1 in 5 Canadians experiencing a mental illness or addiction problem. And we have to come up with new ways of thinking about how to treat this because fundamentally we have to look at the uniqueness of each of those individuals, and we know how much the individuals experience and their friendships with and their families and the impact on society actually uh, affects all of us. And so what we're looking at is how can we use data about each individual to improve our ability to diagnose them and to treat them. And by taking into account things like genetics and cellular and synaptic makeup and circadian data, their sleep patterns, social influences, lifestyle, and behavior. If you think about it, the big uh, companies, social media companies, know a huge amount about you. They're able to gather that data and put it together and make predictions about you. Now, they tend to do that to market things to you. We're looking to see how can we put everything we know together in order to better diagnose and treat mental illness. So for example, from brain imaging, this is fiber tractography. This reveals the connectivity throughout the brain. Each brain has over 100 trillion synaptic connections, and each individual has a very unique connectome coupling different brain areas. So our goal is to be able to harness that data and use personalized computational models to transform mental health. So we imagine being able to give each patient truly personalized treatment, be able to test reactions to drugs before it's been taken, be able to improve our ability to succeed with mental health treatments, and be able to also fundamentally decrease how stigmatizing mental health illnesses are, uh, because if we can tangibly understand the underlying biology and mechanisms, then it's not going to be said, well, it's all in their head, right? This is something that is physical, it's real, it's biological, and we want to be able to give that tangibility. So mental health is not only a question of understanding the human brain as a system, but it's also about understanding the uniqueness of each human as an individual. So at the Krembil Center for Neuroinformatics, we're accumulating large amounts of data, we're using computational models, and we're developing new approaches to personalized medicine. It's early, but we are learning how to apply the power of artificial intelligence and computational modeling to build better integrated pictures of each individual. And I'll take you through some of those concrete steps that we've been taking. We're unique in that we're really a data-driven organization focused on the neuroinformatics, focused on combining neuroscience and data science and machine learning, embedded within a hospital. And that's the Center for Addiction and Mental Health in Toronto. We're also operating in a very flexible, agile manner, iteratively collaborating with the clinic, iteratively developing tools, testing them, and adapting, which is essential to learn how to do this. We're also building a platform, and this is a platform for integrating, organizing data, making it possible to share that data worldwide in order to accelerate discovery collaboratively. So overall, we're really tackling that challenge of how do we transform mental health to a data-driven science. And at the core of that is a grand challenge. It's a really profound challenge, which is that we don't have a biological definition of any mental illness. Right now, mental illnesses are defined based on symptoms. Collections of symptoms in the DSM-5 kind of guide clinicians for a diagnosis. We want to move that to the next level. How can we understand ways in which to characterize each mental illness at the levels of, for example, the genes, the cells, the circuitry, the networks within the brain, ultimately build better models that help us identify and predict where in the biological system is the malfunction or is the target of a treatment. And one piece of that challenge is just neuroscience and neuroscience data. There's a huge amount of data being generated worldwide. There are large-scale brain initiatives generating data from the subcellular level, individual cellular transcriptomes, cellular level recording from tens and hundreds of thousands of neurons, tissue level imaging entire pieces of living brain to try to understand what's happening with the activity in it, and then whole brain scale and behavior. And then beyond that basic neuroscience data, there's the challenge of how do we organize and search and combine that layers of research data with the clinical data in order to build an integrated picture that really bridges between the neuroscience and our understanding of the underlying biology to the clinic and the perspective that a clinician brings to each individual patient. And so one of our ambitions and what we've started on is building an integrated data bank of different kinds of data collected with the consent of patients across different disorders and using all of the different measurement tools from the genomics to the molecular neuroimaging, wearables, and so on, to try to accumulate enough data that we can look across disorder and across the lifespan to understand better which factors really are implicated in each mental health condition and each individual. One of the things that we're learning is that there are principles, there are common factors actually across virtually every single neurologic condition, psychiatric condition, and substance abuse disorder. And so we're using that fact and these observations to help guide our research, to kind of give a framework for looking, for example, changes in brain excitability, how quickly and how much the brain reacts to, for example, stimuli from the environment. Those changes are observed in virtually every single neurologic disorder, developmental disorder, affective disorder, and so on, throughout, in different areas of the brain, but across disorders. Similarly, connections in the brain are shown to be altered. Connectivity in the brain is altered across disorders. At the same time, every single disorder is associated with some kind of a disruption in sleep and brain energy metabolism. So the way the brain actually consumes 20% of your body's energy. And one of the things that is seen is that the energy that it consumes actually is significantly impacted with mental health disorders and brain disorders. And similarly, there's an immune response and inflammation in the brain. So that seems to be implicated and coupled to long-term progression of mental health disorders. And so all put together, we're looking for the causal links between each of these factors, between brain excitability and connectivity, connectivity and sleep, sleep and energy metabolism, metabolism and immune response, and how all of that together impacts the cognition, the ability to think and to have memory, and also impact behavior. One of the examples of this kind of change in excitability with aging and in depression actually is studied by Professor Etienne Sibyl, who's also at CAMH. He has focused in on one specific brain circuit. It's really minuscule, at the hundreds of micron level, looking at pairs of neurons, and one neuron inhibits another neuron. And when that goes wrong, when that inhibition is affected, the circuit becomes hyperexcitable. It reacts too much. It reacts too much to stimuli. And that seems to be at the root of cognitive dysfunction and other factors in terms of memory performance with both aging and depression. And so if we can zoom in on some of these mechanisms, we can hope to get a better treatment and target specifically those cells, those synapses, and make better designed drugs and therapies. And one of the tools that we're building and that we've been using to gain a better understanding of how those interactions really make a difference to the overall circuit excitability, it's really to use something we call integrative multi-scale modeling. Now that's a big fancy word for essentially saying we take all the data that we have about the building blocks of a brain circuit, we organize that data, we put it into a computational model. So these are systems of equations that we solve using supercomputers. And by running simulations with that, we can start to evaluate the ways in which different neurons and different synapses all interact to produce a network response at the level of a circuit. And then we keep iteratively doing that, because it's not that you build this once and you're done, but you use it as a tool to understand, for example, why would a genetic change in one individual actually impact a circuit level or a system level or a whole brain level by moving across those levels with computational models. And this work that I was involved in the Blue Brain Project in Switzerland, this is from the Blue Brain Project, where we've had to learn how to do this by integrating data from the laboratory, measuring and characterizing individual neurons and synapses, and profiling a single circuit in the brain. And learning how to apply machine learning methods to build computational models of each individual neuron that helps us understand how does that biology, how does that actually function, and how does that impact sensory information processing, for example. And to do that, we had to reconstruct many different examples of the building blocks of this brain circuit. And you can see there's so many different types of neurons. There's 207 morphoelectric types. So this is different kinds of neurons in one 0.5 millimeter by 1 millimeter tall circuit. And by putting all of those together, we could actually build a digital reconstruction of this microcircuit, recreating the virtual space and the virtual connectivity between these neurons by placing them in the three-dimensional volume, and then looking to see where do the fibers that communicate, the axons, come close to the dendrites of the other neurons, and using that to provide a constraint for the connectivity between the neurons. And this is a view on the inside of that, putting that circuit together virtually in a computer model. And then by using that computer model, here there's 31,000 model neurons all assembled in this virtual circuit. But then we can layer in everything that we know about the ion channels, these proteins in the membrane that govern the excitability of the circuit, the synapses, all of the details, and run simulations that kind of show us now, this is showing us the electrical activity within this circuit and how all of the neurons are working together to produce this low frequency oscillation. This you see there's a rhythm to this. This rhythm is actually very similar to slow wave sleep. When we go to bed at night and we're in a deep sleep, there's this low frequency oscillation. Now this computer model actually gave rise to that rhythm on its own. once we put all of the pieces together, it started to generate. That's an intrinsic property of a cortical circuit. And so that gives us a tool then to start building virtual brain slices and running more what we call in silico experiments, where we can test in a computer how well does this circuit respond? What happens if we change this aspect of the environment or apply a drug? We can do different kinds of simulations. Now, it's not giving you the full set of answers, but it's a tool to really start to dissect and understand the impact of, for example, genetic alterations on the circuit. And one of the things that we learned is that if you have a factor like extracellular calcium, changing the excitability of that circuit, you actually get completely different responses to stimuli. And that's what's shown with the hyperexcitable condition. If you give a little bit of stimulation, you get a giant response in the hyperexcitable case. If you've got normal excitability, you actually get a very precise reflection of the input. And so you're carefully integrating and reflecting the stimulation in that input. And these are two very different conditions of exactly the same circuit with one change in the environment. So this is, again, a tool for understanding the cellular and synaptic contributions to excitability, which we know is deeply implicated in brain disorders. So how do we bring that back to the clinic? And the way that that works is really through an iterative, patient-centric approach, where we're working with the clinicians, understanding how can they better provide care for the patient, how can we provide tools that help that process, bringing that back to the researchers and clinicians and the data and technology providers, and then thinking about how can we use that engagement, that collaboration with the clinic and with the patient to gather data that can inform these computational models. And then that's an iterative approach, because you don't solve this once. You have to learn how to do this together as a system. And we've been doing that. We've established the CAMH Brain Health Data Bank. And this is a process by which we are accumulating, again, with the consent of the patient, individual level patient trajectories, so we can follow how well an individual is doing and their blood tests and their medication dosage, track that over time to build up a rich picture of each individual. At the same time, we're deploying tablets in the clinic and decision support tools for the clinicians to have a visualization in a glance. They can see the history and the progress and the evolution of an individual patient's care and their journey through care. And then we're now working on layering in research studies on top of that care so that we can try out things like wearable devices and mobile technologies and additional biosamples to start to gather additional information, for example, sleep and activity, so that we understand how active an individual is at night. The clinicians are often asking, how did my patient sleep? That makes a huge difference. And that is also a key link to the underlying neuroscience and the biology, understanding the excitability of the brain circuitry, as well as portable EEG, which gives us ways to look at that activity. And we're accumulating all of that data in this data bank, which is a large-scale, multi-scale brain health atlas, accumulating data across the lifespan, across disorders, to serve as a resource, not only for CAMH, but for the world. And this gives an example of one of those decision support tools that we've collaboratively built with the clinicians, which actually shows the individual patient trajectory over time. How well are they doing? What risk factors are there? What's their medication? And we're also working with patients and families to design a chart for their viewing and their engagement in helping serve their interests. So all of that data now, and this is now where we're headed, is to use the data that we're collecting to make what we're calling digital twins. And this is a concept that's been used in industry for a while, but to build using neural networks and deep networks of various kinds, integrate all the data that we have about each individual into a model that will actually predict individual trajectories over time and then identify opportunities to intervene, to improve diagnosis, to look at similarity across different patients, and look at more effective treatments in order to better inform the overall treatment trajectory. And we're starting to build a national network to say, if we start to do this earlier, if we start to apply standardized measurements early on, and we accumulate from all of the research studies that have been done, pictures of the first 1,000 days of each child, can we intervene early and often with basic measurements, with early things prior to going to school to improve the overall outcome and school readiness of each individual child? One of the things that we see as an opportunity is using wearables to gather very useful information like sleep and sleep architecture, which we know has a direct link to that neural activity. By using heart rate and wrist movements from, for example, if you're wearing an Apple Watch, it's got all of the machinery in there to actually build up a reasonable profile, a reasonable picture of your activity during the daytime and your sleep structure at night, and use that as a way of adding to the overall assessment and treatment for each individual. And we'll continue to iterate. We will continue to iterate on these decision support tools and layer in additional information and work closely with the clinicians and patients and families on what information is most informative, most beneficial in improving the treatment process. Overall, this is really about creating a learning health system. So on the right, we have a loop where we're working with researchers. We're accumulating the research data. We're using AI and machine learning, computational models, and building up better and better modeling processes. On the left, we're collaborating with clinicians and patients and on the care delivery and clinical decision support and improving the quality of the data, and all of that being fed into the electronic health record. And it's really where these two worlds combine, where research is integrated with care, where we can do pragmatic trials and layer in new measures in collaboration with patients and clinicians to identify how can we better inform care for the future patients and improve the overall process. So I want to just first thank the Krembil Foundation, who have supported the founding of this center, and support from the CAMH Discovery Fund, the Kerner Foundation, and technology partners who have really been fantastic. But overall, it's the team as a whole. This is an open science, collaborative team working together to really advance our ability to provide personalized mental health care. And we've got a lot of work to do. So thank you very much for your attention.
Well, thank you too. There's a lot to chew on in there. We have one question immediately to post here out of the chat. Are you planning to use federated learning?
Absolutely. Federated learning is a technique that allows you to kind of build a model in one location on one data set, and then kind of use transfer learning to be able to benefit from that. And I think that's a great opportunity, certainly, as well, taking into account some of the privacy concerns about sharing individual patient level data. Well, if you can train a model that doesn't actually capture any individual level private data, then you can transfer the knowledge across institutions. I think it's a great opportunity.
So as I'm listening and ingesting all of what you're describing, I'm thinking about all of the really positive, beneficial uses for a clinician. I was also a little bit concerned, though, imagining corporate healthcare that gets people to wear different devices and then enables them to know things about their populations. How do we create a better future for the uses of these technologies that are, as you say, doesn't get into the ugly privacy and data use or reuse conditions, but really focuses on interventions that create a more healthy public?
I think it's an incredibly important question. And right now, as you know, every device manufacturer, Fitbit and everybody who's building another watch or fitness device, they're building their own private clouds to accumulate that data and potentially sell that. We saw that just recently with Google buying up Fitbit, right? So they're accumulating this very personal data. And overall, I think there needs to be, I would love to see a common trust with clear governance that people could say, I want my data to go to this common good, right? I want my data to be deposited into this that can be more broadly used by authorized, authenticated researchers to improve care and treatment and diagnosis, rather than all of these siloed interests where essentially the business model is to soak up your data and use it and possibly sell it without you actually benefiting at all.
There's a great question here. There's been a number of studies reporting bias in machine learning, and this is true in healthcare too. Is the application of AI or machine learning in Canada taking any proactive steps to mitigate those issues? Great question.
It's a really excellent question. We've actually established an entire program on equity, diversity, and inclusion within the center. But we also have a health system impact fellow who's doing an ethnography on bias and throughout all of the operations, because the very process of collecting data and the process of delivering care, all of these inevitably have bias. They inevitably have inequity. And part of the only way that you can address that is to make that visible and to bring that to the fore and then have a commitment to improving. And so a critical piece of any learning health system is essentially monitoring in an ongoing way, how well are you doing in terms of representing actual diversity? How equitable is your treatment? For example, challenging populations to serve. How inclusive are you when it comes to a data-driven personalized model? Are you really reaching the full population? And how do you make sure that your data that you're using to build those models actually is reflective of the population you're serving? So I think for me, this is absolutely fundamental. It has to be a core part of the effort. You mustn't put your head in the sand and say, I hope it all gets better. You have to address it head on and build it into the system from the start.
Looking around the corner, I can imagine what's predicted to happen to you because of what your digital twin is doing, being cited as authoritative, right? That model is then determinative in terms of your course of care. Do you anticipate some way where patient advocates, caregivers can challenge such a model or ask for corrections from clinicians if they feel like what the digital twin isn't actually what their person is all about?
I think it's a phenomenal point, because fundamentally, in order to build those models, I mean, what we have learned from all of our conversations with family members is that they know so much more than any record, right? They know the rich history, they know the experience, they know the evolution, and they can be a great resource in refining that picture and building a better model, for example. I think the challenge is how do you appropriately engage and how do you usefully kind of ask the right questions to be able to integrate that data and build better models. But I think it would be a terrible thing to not tap into that knowledge and experience and personal view.
Which countries are doing this right? Here in the United States, as you know, we have a law which is in contention that protects people from being denied insurance based on pre-existing conditions. Now, countries that have guaranteed health care through a national healthcare system have a different situation. But you can imagine these kinds of scans maybe revealing something about someone that could then be relevant. Where should this data live? What's the right model? Who's doing it best?
So I think this is, of course, even in some of the so-called socialized medicine, universal care countries, there are insurers, and this is still a concern. I think there have to be very clear prohibitions on kind of using that data against or somehow to deprive or bias care and treatment for each individual. There are examples of those laws, as you mentioned, being passed, but I think fundamentally, we do have to balance the individual interest in getting better treatments and better care, and the opportunity to partner with industry is an important piece of that, right? And I think it would be a mistake to exclude that. But we do have to have the right model where the terms of that, in kind of a pre-competitive space, are actually benefiting rather than kind of creating an isolated solution that's proprietary just for one particular company. I don't think we have the example right now of how to do it right. And I think
Mhm.
we're going to have to keep learning how to do that.
Are there examples of where it's being done wrong? Like, here's what to avoid?
Well, so there are. I would just say transparency is absolutely essential. And for example, I'm in the UK, where DeepMind had a agreement with the National Health System and to get data, and it wasn't really transparent, and it wasn't really kosher with the laws that govern the data there. And so somehow they got access to data they shouldn't have been having. Maybe it was all going to be good, they were going to do good things, but the process, it created such mistrust.
Hmm.
And it really backfired. So a lot of those efforts actually had to be shut down and kind of move on. So I think real care upfront to the transparency and to the accountability and to the responsibility of how that data is governed is absolutely essential.
So here's two interesting questions. The first is, could the creation of such digital twins reduce the need for animal testing, right? So is there a way you can envisage this being deployed in a way that reduces the need for all these different mammals and labs? And then the second one is interesting in the sense of, uh, if you're talking about creating sort of ongoing ambient monitoring of people, data collection, whether it's in devices that are inside of their body or scans or whatever it happens to be. What's the impact of being tracked upon people with mental health issues?
Right. Um, so I think the first question is a difficult one, because in principle, what it should do is make our research process more efficient, because we should be able to eliminate experiments that are not strictly necessary. But I don't see that anytime in the near future that the computer simulations will definitively replace experimentation, because the biology is still so complex.
Hmm.
And we know that that mouse models are no substitute for human experiments. For example, so many clinical trials fail. It worked in the mouse, it just doesn't work in the human. We're nowhere near having a computer model that is going to be that definitive either. So it can help, it can reduce, it can improve reuse of data. I think those are critical, important things. Um, and the second question really about this pervasive monitoring, and I think we have to have security, we have to have privacy, we have to have data governance that ideally really prevents any kind of misuse of this data for discrimination, of course, further stigmatizing. My hope, and this is a hope, I would hope that the more we learn about the underlying biological causes and the ways in which data can help better diagnose, the more we'll recognize that these are real disorders, that there are real underlying biological causes, and that we, by measuring them concretely, um, we have a better hope of treating them,
Yeah.
and that it shouldn't be something to dismiss and diet. There's so many cases still to this day where youth suffering from early trajectory towards psychosis is maybe discriminated against because they're just they're what's the matter with them, why can't they just be normal, right? But
Mhm.
we have to recognize that this is real and it has to be treated early, and we can't allow that stigma to prevent seeking and receiving care.
Well, if you can found this in biology, it's just some very interesting places. I have friends, family who've type 1 diabetes, and they have an insulin pump
Exactly.
that it's attached to them and attached to an app, right? I mean, they are
Right.
cyborgs in a very real sense, but for them, it's helping them to manage either their own needs or their children's needs or someone else. And uh, I can envisage a personal agent, right, who is constantly checking in that has privacy within that scope. What are the most promising approaches to give people that kind of ongoing personalized precision medicine that might help with those kinds of interventions for mental health?
Well, it's a really great way that you pose that. And in fact, very, you know, real versions of that have been developed at CAMH already, AI for Health and this app to help
Mhm.
support individuals with schizophrenia just to manage and to monitor their symptoms, monitor and have social supports and have some tools for checking whether or not an auditory hallucination is something real or not. So there's support tools already which can start that. And then you can imagine layering in real computational models, machine learning tools that really help give another layer to that. And I think it's very possible. I think that that personal agent that you're talking about is the right model, right? We all need support at various times. We all need self-monitoring and knowing when do we need to seek care. And I think actually what we need everybody in society to be engaged in monitoring their own mental health and catching the warning signs early and
Mm.
often and treating that before you have to go into an institution for a more severe case.
So, Alexa, what do I need to do to manage my well-being today? Let's see how that goes.
You're
Uh,
scaring me.
Yeah. So I've got 3 minutes left here. I've got a couple more questions here. Here's one. How big of a data pool do you need to have meaningful data here that can be used? Right? Because you can imagine personalized medicine where it's just one person going back and forth. But to make population level determinations, to make that connection between this particular way a brain is made and someone's mental health, what do you need?
So it's actually something that we're learning as we go because when we first started off doing, for example, associations between brain imaging and genomics, the genetics of an individual, it turns out that we started to see, well, there's so much variability in the genome, you have to have much bigger numbers. Now, that's not necessarily going to be the same for collections of behaviors, right? It's not necessarily going to be the same for neuron types, right? So there's going to be at different levels, depending on what we learn, different amounts of data necessary. But the reality is we need a lot. We need to understand the scope of the diversity that is out there. We know that there's incredible diversity genetically. We know that there's incredible diversity in terms of mental health disorders, and we know that there's incredible diversity of response to treatment.
Mm.
And so we simply have to be accumulating as much data as possible, as high quality as possible, in order to understand how well can we actually transform this. We're really at the beginning stages. We have on the order of 1,000 patients worth of data accumulated just from the start. We expect that to grow significantly. There are 30,000 patient visits a year, or 1 million patient visits a year, 30,000 patients per year. So just at one institution, I think we should be collaborating across hospitals. We should be collaborating with a common trust to integrate that data to better inform treatment everywhere.
What's the one question you never get asked but wish you were about your work?
Yeah, that's a good one.
45 seconds.
um, I get asked all kinds of questions. But is it fun? Yeah. Personally,
Hmm.
it's incredible. Every single day, there's a new challenge. There's incredible complexity to tackle. The diversity of human experience is absolutely incredible and so integral to understanding mental illness and how to treat it.
Well, that's a great place to end it. So, if you haven't noticed, Dr. Hill is at Wake Sleep on Twitter. This has been a fantastic conversation. Looking forward to learning more about your work and seeing this area develop. I hope that you can keep setting high ethical and moral standards for how this work goes, and genuinely that you can help people. There's so much upside to applying these things for good, along with the downside we discussed. So thank you for your time. Thank you for your insight. I look forward to seeing you online. Take care.
Thank you so much, and thanks for all the fantastic questions.